It's Ulrich Sidney here, President of the Association of Future African Neurosurgeons. Today is the first couple of presentations for the year 2020. We're so happy to have all of you here. The very first presentation would be by Dr. Natalie, PGY1 resident in neurosurgery at Abidjan. But before we start, we're going to have the different members, the people around, present themselves. Dr. Abdullahi Jimo. You're muted, Dr. Jimo.
Yeah, everyone, and welcome to 2020. We hope this year will be a fantastic year in the program, and some of us will be more available. I am Jimo. I'm a neurosurgeon in Nigeria, but I'm currently in Rabat, Morocco for fellowship in stereotactic gamma knife and functional neurosurgery. Thank you, Eric.
Thanks, Dr. Jimo. Dr. Leo Yanu, can you present yourself, please? Please unmute yourself, please.
It's okay?
Yes, great.
Okay. Hello, I'm Leo Yanu. I'm a medical doctor from Cameroon, general practitioner and aspiring neurosurgeon.
Nice to meet you. Thanks for being here. Dr. Igor Nietzsche, can you present yourself, please?
My name is Igor Nietzsche. I'm from Cameroon. I'm second year residency in neurosurgery at Abidjan. I'm happy to be here.
We're happy to have you as well. Thanks very much. Dr. Marco Meloni.
Hello everybody, and Happy New Year to everybody. My name is Marco Meloni. I'm a consultant neurosurgeon in Gravedona, North Italy.
Yes, always a pleasure to have you around. Dr. Augustino Jacinto. Dr. Augusto Jacinto. I think you're muted. You will want to unmute yourself first.
Hello. I'm here. I'm talking from Mozambique.
Yes, we can see
Hello.
you.
Hello. I'm talking from Mozambique.
Okay, great to have you.
Thank you.
Obrigado.
Happy New Year.
Happy New Year. Dr. Aminata Salah, can you present yourself, please? Maybe you're muted because we can't see you. We think maybe you're speaking and we can't. Okay, no worries. Now that everyone's presented themselves or muted themselves, we're going to have Dr. Natalie give a presentation. Please, everyone, mute yourselves. Go ahead, Dr. Natalie.
Okay. Hello, everyone, and Happy New Year to AFN and all those who associate with AFN. Sorry for the late coming. I thought I was presenting after Daniel. So today I'm going to present on, let me just say, complete my presentation on the management of acute ischemic stroke. Today I'm going to present on the surgical indications of ischemic stroke. As we said previously, the WHO defines stroke as the sudden onset of focal neurologic dysfunction in which, after adequate investigation, symptoms are presumed to be non-traumatic but of vascular origin, and it lasts for more than 24 hours. Cerebral ischemia is caused by the reduction of in cerebral blood flow, as you can see. That lasts longer than several seconds. The etiologies are many, which the main etiologies are we can find cardioembolic etiologies, embolic etiologies, or thrombosis. But uncommonly, we can also find the Moya disease. In our country, have already been faced with a case of ischemic stroke after eclampsia. Current available medical treatment of of ischemic stroke includes thrombolysis and anticoagulants to deal with the later complication of malignant edema and raise intracranial pressure. Medical treatments such as mannitol, hypertonic saline, and barbiturate coma, or hypothermia or hyperventilation have been proposed, which are reasonably proportional, but they are not really effective. These medical solutions to treat malignant edema has not proven effective, have been effective in preventing breath herniation and improving patients' outcome rather than surgical treatment. And that's what we'll focus about today. The surgical treatment for stroke can be classified into either an acute or a non-acute treatment. Acute interventions are usually initiated within hours of stroke onset, and they are aimed at reestablishing the cerebral blood flow, restoring the loss of neurologic function, and preventing permanent tissue damage. While the non-acute surgical therapies focus on reducing secondary injuries resulting from brain swelling or preventing recurrent stroke. As for the main acute intervention, we have the endovascular mechanical thrombectomy. We talked about it on the last presentation some few weeks ago, which consists of clot retrieval. Usually the indication here is patients who have the contraindication for thrombolytic treatment, or those who fail to achieve vascular recanalization with IV thrombolytics. Here we have an image which shows two different types of clot retrieval. Here is the penumbra clot retrieval, and here is the stent clot retrieval. 10% of ischemic strokes result in large areas of infarction. This can lead to significant brain swelling, an increase in intracranial pressure, and in severe cases, life-threatening herniation syndromes. As you can see, we have the cingulate herniation, we have transcalvaria or extracranial herniation, orchid herniation, upward cerebral herniation, or even tonsillar herniation. For the anterior circulation, the decompressive hemicraniectomy is usually proposed. Usually when there is a significant edema that occurs in the supratemporal space after a stroke, it is referred to as malignant infarction of the middle cerebral artery. How is it done? What's the technique? After a standard question mark in skin incision, we will perform a muscle and soft tissue reflection, anterior reflection. And then we create a bone flap with at least 3 burr holes. The bone flap is then removed anteriorly and posteriorly. We remove the bone flap, and the residual temporal bone is cut by rongeurs down to the floor of the middle cranial fossa for maximal decompression of the brain stem after removing the bone flap. Then we proceed to a dural opening. That's we perform a radial incision of the dura mater in order to maximize cerebral decompression. Underneath the dura mater, usually we have the zone of infarct, the zone of infarct, which can be resected. Then we close the skin scalp with a suture or a staple. There continues to be a considerable amount of interest in the use of decompressive hemicraniectomy in the context of malignant middle cerebral artery infections. There is now a significant amount of evidence that it is a life-saving intervention. However, it is by no means restorative, and many patients will survive but remain dependent, especially those patients over 60 years of age. For those patients on whom surgery is considered beneficial, there remain some issues regarding the timing of surgery decompression and complications of the initial decompression and subsequent reconstructive cranioplasty. In the early 2000s, 3 multicentric randomized control trials have been conducted with favorable outcomes in patients who underwent decompressive craniectomy for the treatment of large middle cerebral artery ischemic stroke. These studies were mainly done in Europe. We have the decompressive surgery in 2007, 2 of them were being carried out. We have the decompressive surgery for the treatment of malignant infarction of middle cerebral artery. That's the DESTINY, abbreviated DESTINY, which was conducted in Germany, and the decompressive craniotomy in middle cerebral artery infarcts, abbreviated DECIMA, was conducted in France. While another one in 2019, the Netherlands, the hemicraniectomy after middle cerebral artery infarction with life-threatening edema trial was conducted. All these different trials concluded that patients who could undergo this decompressive hemicraniectomy are patients who were under 60 years of age and who were under 60 years of age and who came before the 48 hours after onset of the stroke. So yeah, the question is asked ourselves, when should we perform our decompressive craniotomy? The answer is as early as possible if the patient have predictive features. This is a level 1 CEO recommendation. As we said earlier, we have patients who are aged. This diagram is trying to resume the different indications of patients who can undergo decompressive craniotomy at their entry. First of all, we have to ensure that the patient is less than 60 years. And we have to consider comorbidities if the patient is greater than 60 or greater is 60 years or above. The surgical timing should be less than 48 hours because usually when these patients, there is no functional, there's a better functional outcome with patients with who arrive, on whom the decompressive craniotomy was performed less than 48 hours after the onset of the stroke. So these are some predictive factors which determines the choice of the patient who undergo the decompressive craniotomy. We have clinical, biochemical, and the radiological parameters. For the clinical parameters, the NIHSS score is the main determinant. That's a patient who arrives with a NIHSS score greater than 20 for the dominant hemisphere and greater than 15 for the non-dominant hemisphere within the 6 hours. These patients should undergo decompressive craniotomy. We have also a patient who arrives with nausea, vomiting, or hyperthermia. This patient can be considered to do a hemicraniectomy. There are also some biochemical markers such as the hyperglycemia, leukocytosis, and an elevation in the protein S100B levels. These patients should be considered as considered to be highly predictive of having a malignant edema. We should note that the role of intracranial pressure monitoring in this patient is limited, as neurological deterioration can occur without an increase in intracranial pressure. As for the radiology features, a hypodensity greater than 50% of the middle cerebral artery territory, the involvement of the anterior cerebral territory and the posterior cerebral posterior artery territory or the basal ganglia are highly predictive of a bad outcome. A midline shift on the CT scan or diffuse weighted MRI, a midline shift as well as an infarct volume greater than 145 milliliters is highly predictive of a patient who should undergo a decompressive hemicraniectomy. So on this table, I'm trying to, this is the NIHSS score. The NIHSS score, as we talked about, the NIHSS scale as we talked about earlier. This scale was described in 1989 by T. Burt, which helps in the clinical as a clinical prognostic tool in the planning of revascularization treatment with recombinant tissue plasminogen activator. It is also a predictive. It also predicts the patient's outcome. This tool is made of. This scale is made of 11 points. We have the level of consciousness, the response, the best gaze on response, the visual response, the facial palsy, the presence of a facial palsy, the motor arm response, the motor leg response, the limb ataxia, sensory response, the best language, dysarthria, and extinction and inattention. A patient with a zero score, with a zero knee score, is considered to have no stroke syndrome, while a patient who is greater than, who has a knee score greater than 16 has a really bad or poor outcome, clinical outcome usually. On this second image, we have the image, a CT scan of a 54 years old female patient who underwent a decompressive hemicraniectomy after a large impact of the middle cerebral artery. So we can see here the impact. It was really large, and we can see already the brain already herniating, and the midline shift is being reduced. We can see here how the midline shift, due to the hemicraniectomy, you can see the midline shift, which has already come back to its normal position. On this flow chart, we try to explain a little algorithm on how we choose our patients, the patients for a decompressive surgery. When a patient arrives, a thorough clinical and radiological assessment should be done. If the patient has an ischemic stroke, then we put the patient on a massive medical treatment, and we should ensure ourselves that we are less than 48 hours after stroke onset. If the if his clinical status worsens, then we have to ensure ourselves that the patient is, first of all, less than 60 years, has a fair neurological status or few comorbidities, even if he's greater than 60 years, then we can do the decompressive surgery. As for posterior circulation infarcts, they usually lead to obstructive hydrocephalus or massive edema. The treatment of this obstructive hydrocephalus is ventriculostomy. This ventriculostomy should be associated with sub-occipital decompressive craniectomy in order to prevent an upward cerebellar herniation. While the massive edema, we can only do the sub-occipital decompression. This is recommended except for a patient who presents himself with a lateral medullary syndrome, which is usually due to a primary brainstem ischemia. During this sub-occipital decompression, we have to enlarge the foramen magnum, and then the dura is then opened, and the infected cerebellar tissue usually exudes like toothpaste, and is easily aspirated. So we have here an image of a ventriculostomy that's on the third ventricle. And we have there an example of the sub-occipital decompressive craniectomy. You can see that the foramen magnum has to be enlarged a little bit. Finally, we finish our treatment by doing a cranioplasty. It is important to do this craniectomy because it helps to rehabilitation. It helps in rehabilitation of the patient. It restores the cerebral protection and cosmetics. And in certain patients, it also improves neurological function. This cranioplasty could be done with the bone flap that we early prelevated, that's removed, or it can be done with a synthetic flap like this made of polyether ketone, which is usually done in our country. I've never seen that, but I've already seen a craniectomy with a cranioplasty with a bone flap, which was previously conserved under the skin, that's on the subcutaneous skin of the patient. These surgeries are usually sometimes followed by complications. Post-operative, we could have post-operative subdural or extradural complications for patients who undergo decompressive hemicraniectomies, or even we can have a syndrome of the Trifine. This is usually a rare complication after craniectomy, where with a sunken skin above the bone defect. It is usually accompanied with neurologic symptoms such as severe headache, mental changes, focal deficit, or even seizures. As for the complication of the cranioplasty, we could have sudden death. We could also have subdural or extracranial hematoma, and we can have also a bone flap resorption. On this slide, I try to show out what is the modified Rankin scale. It is mainly a prognostic scale on the ability or disability of a patient who has stroke. When the patient has no symptoms at all, then the prognostic, the functional prognostic value is good. While when the patient goes, the Rankin scale climbs, that's from no deficits to severe disability. We have a patient that is likely to have no functional recovery or difficult functional recovery. This study, a study was done, the study done by Hamlet in Netherlands in 2009, showed that patients who came, as I said earlier, who came, on whom decompressive hemicraniectomy was carried out before 48 hours after the onset of strokes had a significant reduced probability of severe disability or death than people who came after 48 hours onset of stroke. We shall talk about the different preventive methods that are used for in ischemic, acute ischemic stroke. As we said in our last presentation, there is a carotid endarterectomy, carotid angioplasty, or stenting. Usually, despite the proven effectiveness of carotid endarterectomy, carotid artery stenting has been promoted as an attractive, less invasive option for revascularization. There are potential advantages of carotid artery stenting includes decreased patient discomfort and shorter recuperation period. But after the carotid revascularization endarterectomy and of a stent trial, they discovered that they had similar outcomes. So if the patient is poor, we can still do the endarterectomy. They have no problem. They have the same outcomes. Finally, patients could undergo extracranial to intracranial arterial bypass. Unlike in the carotid endarterectomy or carotid artery stenting, there is no benefit for patients with atherosclerotic carotid occlusions or carotid artery stenosis. This technique is usually beneficial for patients who have the moya-moya disease. How is it done? We use an extracranial arterial supply, usually the superficial temporal artery, which is and then we anastomose it either directly or indirectly to an intracranial cortical artery. To conclude, we say that surgical indications of anterior ischemic strokes depends on the NIHSS score, biological and radiological predictive values. The time to treatment is a critical factor in improvement of outcomes in these patients, and the development of additional strategies to decrease time to intervention are warranted. Decompressive hemicraniectomies for anterior circulation strokes and suboccipital craniectomies for posterior circulation strokes are valuable operations for the life-threatening consequences of malignant edema after stroke. So these were our references, our different references, and I will say thank you for your attention.
Thank you very much, Dr. Gomsi. Thank you so much. It was a good presentation. Before we move on, I guess we'll have a few comments. We can start with the consultants here, Dr. Meloni, Dr. Jimo, if you have any comments.
Hello once again.
Yes.
Nice presentation, Natalie. That's a good one.
Thank you.
It was very clear. Now, I think your topic is surgical indications for ischemic stroke. I expected you to, first of all, give a background, basic physiology, anatomy. You tell us about the circulation of the brain from the carotid, vertebral, artery, in a single or two sentences for us to have that that clear in our mind. And what you are talking about is deprivation of blood supply to the brain and the consequence or the consequences. Therefore, management of ischemia, we have to have a background knowledge of the blood supply to the brain, you know, the cerebral blood flow. We need to know that. We need to know the normal, the abnormal, or the midpoint where things are still reversible. And we are talking about ischemia is time bound. We are talking about something must be done within a very short time. We have to know what ischemic penumbra is. You know, so like cerebral blood flow, it has to be 50 or thereabout mils per 100 grams per minute. What ischemic penumbra is, what you have to do. These are rather a bit abstract, not surgical in the sense of it, but you need to know all that. And once it happens, what needs to be done? In most cases, is medical. Then now you have to come surgically, and that is the essence of the presentation, surgical indication of ischemic stroke. So mostly, the consequence is what you dwell on, what you are dealing on mostly, which is edema. But can you do something apart from the edema to revascularize the brain? You talked about the ECIC, Shanti, Moya disease. Excellent. Now, and again, we have to know what acute ischemia is and chronic ischemia. Acute ischemia, a lot of it depends on time. You know, you have to do something medically, surgically, you have to do things, endarterectomy, or you have to remove clot from the vessels to prevent further, because this thing is time bound. 3 hours, if nothing is done, medical surgical extension, I guess you use the whole essence. Then you should have also introduced this acute ischemic stroke and chronic ischemic stroke. In chronic cases, you might be dealing with the consequences. And the consequence, stroke has taken place, the cerebral cortex has a problem and is generating problems. Let's say seizure, you have to do something. It's an indication for surgery in some instances by extension. I hope I'm not getting too deep in this matter. I guess that's the way I see this topic actually. But in essence, you've done extremely well. That's my contribution. Thank you.
Well, thank you very much.
Thank you, Dr. Jimo. But the problem is, I had already a presentation that we did where it was much more detailed, and this was just a second part. That's why I was taking an example of previously we talked about. So it was just a continuation or a completion of what I did.
Sorry, I wasn't part of that. Sorry.
Yeah,
yes.
Sure.
All right.
Thank you.
Okay, Uri, go ahead.
Yeah, thanks so much. Dr. Milon, do you have anything you want to add maybe?
Well, I totally agree with Dr. Abdullah. It was a very well done presentation, Natalie. I appreciate a lot how do you highlight the surgical indication for the compressive craniectomy, because not in all patients the compressive craniectomy create a good outcome for the patients. When the patient is in a neurological status that is going more and more worsening, the compressive craniectomy sometimes is successful. You just you don't get any good outcome, but just a vegetable status is not good at all. So I appreciate a lot of that. Thank you.
Thank you, Dr. Malcolm.
Thanks. So obviously really good presentation. I think I would like us to discuss a bit about the last time the patient was seen as being well, and what are the different strategies or managements we can propose. if you want to contribute, and obviously given our context, maybe make it more specific to our context, because it's a bit of an issue, I guess, because we've had endovascular techniques at one point. We've had pharmaceutical treatments, and then at one point in time, it's like, oh, that's not the best. Let's go back to this. So it's changing a bit. Just your point of view on that.
Yeah, of course, we need to highlight, Ulrich, that this stroke is a multidisciplinary topics that involve endovascular, involve neurologists, involve neuro anesthesiologists, and neurosurgery, of course.
Okay. Yeah, Dr. Kabulo, Dr. Jimo, do you have anything you'd like to say about this? The different management options available, perhaps for stroke management in low and middle income countries, and maybe even the prognostic. I guess in that case, it's a bit difficult to have those to decide how to take care of these patients.
Oh yes, just like what Dr. Maloney said, it's a multidisciplinary approach that you use in managing patients with ischemic stroke. Now, when the patient comes around, well, it has to be a setting where people are alive to their responsibilities. You see, and the outcome depends on the training of every aspect of this multidisciplinary team. Now, the first caregivers, like where ambulance exists, and of course in low income countries, some of these things don't exist. First of all, it happens at home. The patient is discovered by relations somewhere not behaving how he's supposed to behave, or is unconscious. First of all, people will run around, shout, later get the patient. Mode of transportation to the hospital is difficult, and what you meet in the hospital is a bit not ideal. Okay, so since this thing is time, we all depend on time in this matter, we are losing time. And as the patient goes into the hospital, there are criteria, actually, inclusion and exclusion criteria, and even doing the first thing to the patient. First, you are supposed to know what the problem is. Is it stroke itself? Is it severe hypertension only? Is it hyperglycemia, hypoglycemia? Is it any other thing, a gamut of other things that could be happening? We don't have the tools to immediately know what the problem is. You have to do brain imaging, initial blood tests to know what the clotting issues are, because you can't even do certain basic things until you know what the basic level is. You have to know the clotting. Assuming from your clinical history, you have the suggestion that, of course, this could be stroke, ischemic, hemorrhagic, or okay, you say it's ischemic stroke, commonest. Now, what do you do next? You need an image, because you can't give blood thinners without having an image, because it could be hemorrhagic and you can't compound the patient's situation. With all these things, you are losing time. So if the diagnosis is made, basically, first thing is medical treatment. Do you give hypoglycemic if the hypoglycemic agent if the blood sugar is high? Do you give how much you bring the blood pressure down if the blood pressure is high, which is common in with ischemic strokes? You do an image. There bleeding, there is none. Is there edema, which Dr. Natalie expressed on mostly? If there is, of course, ischemic stroke, what type do you give in our setting? Which one is available? They could be expensive. How much do you give? Is it a general thing? There are inclusion criteria for giving blood thinner. If not, you could compound the patient's problem. A lot of procedures in the past, the history, which must be very, very clear. And in our setting, the provider or the person that is bringing the patient might not have a good record of what the patient is or has been taking, or has not been using that medical setup. So there are no records. So brings a lot of problems. Now, if all medical aspects are explored, and in this instance, the multidisciplinary team, everybody must be around, the anesthetists, the neurologists, the surgeon, the cardiologist, the cardiac surgeon, depending on what we want eventually. If this surgical aspect is indicated, it means endovascular form of treatment or selective vessel infusion of anti or thrombolytic agent. These ones, all I'm talking about, are not clearly available in our setting. However, we try to, in the interim, do much to see how much we can keep the patient on. That is for acute edema. As a neurosurgeon, what is when there is massive edema, decompress, and that one will remove the risk of edema that will further cause herniation and further cause problem. And that is what Natalie stressed upon, which is fantastic. That's the first thing that's the stage we are now. Then the next is, as in the ischemia is chronic, it still has surgical indication because there's consequence on the patient. Dysplastic cortical area that is generating seizure always, that's another extension of management of ischemic stroke. That's in summary what I have to say. Correct.
Well, thank you so much. So there's you've raised a lot of points about the difficulties in managing these patients in low and middle income countries, and obviously our next question would be, what do we do next? Like, strokes are getting more and more common with the change in the burden of diseases, and we will be seeing more and more of these cases. So yeah, the management, like what can we do to better manage these patients?
Now, there are two aspects to it. One to the general populace, and the second one to the doctors. To the general populace, you have to prevent it, because even in the developed economy, is one of the leading causes of serious mortality and morbidity. So the first thing is we have to prevent it by health education. We have to reach out. We have to advocacy group, a kind of, if possible, multi-country, multi-center, the various stroke groups or societies in various countries will have to be advised or mandated, actually further advised, because they know already, to have advocacy group actually to prevent this thing. How do you prevent it? Is basically the underlying problem, the high blood pressure, the hyperglycemia, not well managed. All those things must be prevented. Health education to prevent all this. And then secondly, to the doctors, what we're doing now is continuous education. We are enlightening ourselves what to do. That's the essence of what we are talking about, actually. Apart from the education, it's also on how to better the care of your patient. So these are the two prongs I see we have to pursue to reduce the burden of this disease. Health education, we have to know the first thing first, just like ABCD. Okay, and that's the essence of this presentation. What do you do medically, surgically, and all other disciplines of medicine to make sure the patient who has suffered stroke has a better outcome in terms of less mortality and less morbidity.
Thank you so much.
If I can add just one thing, Ulrich, another thing is necessary to do to improve the outcome, to improve the patient assistance, is to centralize the stroke unit. Yes. I don't know how is the situation in your countries, but I have experience of some center when the patients came, there is indication for thrombectomy because there is a thrombus in the M1, but there is no endovascular, so the patient needs to be moved in another hospital, or there is need for the compulsory craniotomy, and there is no neurosurgical unit. So as just highlighted Dr. Abdullah, is a loss of time, and remember that time is brain.
Yes, yes. Thank you so much. I mean, there's so that there are a few options, a few technologies I've come across here at the Brigham, and I think they could actually be amazing for low and middle income countries, but that they're having difficulties establishing them here because of so the first one is there's this application that has been developed by a few neurosurgeons here and people at MIT, and the application does what it does is it uses artificial intelligence to once a patient gets a CT scan, immediately as he gets a CT scan, it gives a presumptive diagnosis of, say, for example, a stroke, a subarachnoid hemorrhage. And once it does that, it sends the images and a message to all the members of the stroke unit, for example. So if you're a neurosurgeon, before the patient even leaves the imaging or the radiology unit, before he leaves, you already have a message and you already have the image. That tells you already, okay, we can start preparing. So even the guys at the OR already have the information saying there's a patient coming, we have to prepare, because those are the things we have. We lose a lot of time in developing countries. You get a patient before the guys from radiology tell you it's a stroke, it's 2 hours before the guys at the OR are ready for you to come in, it's maybe 3 hours. And they're having a lot of difficulties using it here because the regulations are really strict. The HIPAA regulations for patient information protection. And I was wondering, this is something that if we can, not necessarily the same thing, but this is something that can work in developing countries, because if we have a centralized unit, for example, I'm thinking maybe in one of the capitals and a patient gets a CT scan in another city, then they already know they're getting that patient. And I think that's one of the ways you can reduce it. Obviously, there's prevention as well. Definitely, there's definitely prevention that we have to do. And I think we as future neurosurgeons, as young neurosurgeons, as consultants, have to start thinking about these solutions beyond just the operative act. Like if we need apps, we need to be working to develop apps. If we need different communications, then we need to do them. We have to do these things. Otherwise, we'll just find ourselves with a whole lot of people just having strokes left, right, and center, or trauma, and we wouldn't know what to do about it.
Yeah, Eric, I'm right, but I think also that we should increase our workforce. Like in Cameroon, for example, I think there are neurosurgeons maybe in something like 4 or 5 cities. 5 cities in Cameroon, and really the workforce is really low. So there are so much problems. There are problems of transport. When are they diagnosing? When are they doing the diagnostic? When are they going to send the patient? How would they send the patient? It is really, and usually, in our countries, for being in Ascovim, for going to our villages, we don't have network. They don't usually have no, they don't even have treatment. Even those medical treatment that we say we are talking, I've never seen the recombinant tissue plasminogen activator. I've never seen it.
Yes.
Since I've started school till date, I've never seen it. So we really have issues where I think we should really include stroke management in the universal health coverage of our countries.
Yes.
That these drugs become more and more frequent for patients or medical doctors to use.
Absolutely, you're absolutely right. And I mean, this is why I'm saying neurosurgeons need to go beyond just neurosurgery. When you speak about the problem with the network, for example, there's things like messages, simple SMS text messages, which go through USSD. You might not have internet, but you can get USSD. And then that means neurosurgeons need to be with the guys who develop these applications and tell them, okay, use this, and this is what we want. This is the least information we want, for example. We want the Glasgow, but that will mean, okay, if we're training people at medical schools, we need to teach them, even if you're going to be a general practitioner working somewhere remote, the least you can give me, for example, is the Glasgow. I expect you to send me maybe a message, tell me what are the symptoms, and this. But anyway, we need to develop this, we need to brainstorm on these things, and we need to come up with solutions. I think that was an amazing presentation. It's always great to have these thoughts flying around.